Hello, and welcome to a presentation on symptom management at the end of life. Quality person-centered care at the end of life requires a holistic approach. Symptom management is one of several aspects to consider when caring for a resident in your facility who is dying. Advanced care planning knowledge, communication skills, and an excellent grasp of assessment and care planning are essential and fundamental nursing skills and will greatly improve outcomes for your resident and their family. Goals of care describe what a patient wants to achieve during an episode of care within the context of their clinical and personal situation. This can be determined through a shared decision-making process. The Advanced Care Directive outlines your preference for your future care along with your beliefs, values, and goals. Having an advanced care directive means you can also formally appoint a substitute decision maker when you can no longer make decisions for yourself. Here we have two examples of tools that could be used at your facility to assist in recognizing deterioration in your residents. On the left, you can see a resident of the day review is used to prompt consideration of medical review and conversations around goals of care with a resident or family. The supportive and palliative indicators tool, or SPICT, on the right highlights specific indicators of deteriorating health in your residents, such as falls, reduced appetite, deterioration in activity of daily living independence, increased infections, and increased hospital admissions, for example. The concept of a dying trajectory was first suggested by Glaser and Strauss in 1965 and refers to a change in health status over time as a patient approaches death. Glaser and Strauss identify different patterns of dying: sudden death, lingering, and the vacillating pattern. Illness trajectories describe the time-related decline of functional status across a broad spectrum of illnesses. A century ago, sudden death was typical, with leading cause of death being from infections, accidents, and childbirth. Remembering at this time penicillin was yet to be discovered. Now in Australia and most developed countries, the majority of people acquire a serious progressive illness. Cardiovascular disease, cancer, and respiratory disorders are three of the leading causes of death and disability today. Three distinct illness trajectories are outlined on this slide. Terminal illness, which is mostly cancer, shows a trajectory with a steady prognosis and usually a clear terminal phase with a sharp decline. Organ failure, often seen in respiratory and heart failure, shows a gradual decline, punctuated by episodes of acute deterioration and some recovery, although often not returning to the previous level of function or independence. These people can appear to have sudden death, which can happen at any time during an acute episode. Or this may be when the resident is admitted to your facility when they are no longer able to manage independently at home. And frailty, typically seen in people with dementia or the aged, is a trajectory with a prolonged and gradual decline. Here you can see a list of some of the most common signs that someone is entering the terminal phase. The terminal phase can indicate the last hours to days of life. Take a look at this list and think about the residents you have cared for when they were in the terminal phase or dying. Have you been able to identify any of these changes? Now we will touch on some of the main symptoms a person may experience in the terminal phase. Note that not all of these symptoms, note that not all people get symptoms, and a thorough and regular assessment of symptoms is required. If somebody is still swallowing, they may still be able to take their adjuvant medications. Examples of this are pregabalin, anti-inflammatory medications, dexamethasone, and paracetamol. Patches can be left on in most circumstances. However, be aware if the client is very thin, the absorption of medication through the skin may be reduced. Even in this late stage of someone's life, it is important to be aware of a resident's liver and renal function, as an erratic or deteriorating EGFR and or LFT are contraindicated for the use of Targin, and particularly with renal impairment, morphine. If you require guidance around navigating this or are concerned about severe pain, you can seek the guidance from your local specialist palliative care team. We won't go into drug calculations in detail today. However, this slide illustrates that converting somebody from oral to subcutaneous morphine is not equivalent. Due to the absorption affecting the potency of the medication, it is recommended that to convert oral morphine to subcutaneous morphine in stable pain, we divide the total daily dose by 3. Describing pain only in terms of its intensity is like describing music in terms of its loudness. The PQRST acronym is used specifically for the assessment of pain. Pain is the most common symptom causing patients to seek medical attention, yet most training is primarily concerned with treating injuries and illness, and hardly any time is spent on how to manage or assess the pain itself. P, or provocation palliation, we want to ask, what was the person doing when the pain started? What caused it? What makes it better or worse? What seems to trigger it? Perhaps stress or position or certain activities? What relieves it? Medications, massage, heat or cold, changing position, being active or resting? What aggravates it? Movement, bending, lying down, walking or standing? For Q, quality and quantity, we want to know, what does it feel like? Using words to describe pain such as dull, sharp, stabbing, burning, crushing, shooting, twisting and stretching. For R, region and radiation, we want to know where the pain is located. Does it radiate? If so, where? Does it feel like it travels or moves around? Did it start elsewhere and is now localized to one spot? S, which is a severity scale. So how severe is the pain on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain ever? Does it interfere with activities? How bad is it at its worst? Does it force you to sit down, lie down, or slow down? And how long does the episode last? And lastly, timing. So where or what time did it start? How long did it last? How often does it occur? Hourly, daily, weekly, monthly? Was it sudden or gradual onset? What were you doing when you first experienced it? When do you usually experience it? In the daytime or the night or the early morning? Does it ever wake you up? Does it lead to anything else? Is it accompanied by other signs and symptoms? Does it ever occur during, before, or after meals? Does it occur seasonally? We also have the Abbey Pain Scale, which is a tool to measure pain in residents who are unable to speak or verbalize pain. With managing nausea, a thorough assessment can help determine the cause of the nausea and therefore the most appropriate treatment of the symptom. The most common antiemetics are metoclopramide and haloperidol. Less common are cyclizine and dexamethasone, which are often used due to nausea secondary to swelling in the brain. If nausea is not controlled, also think about the cause. Ask yourself the question, why is this person having nausea and maybe vomiting? For example, do they have an infection? Are they constipated? Are their blood calcium levels high? Do they have a bowel obstruction? Do they have brain mets or anything else? Delirium is a distressing symptom for a patient, their family and carers. It's a frequently under-recognized symptom. Delirium is the acute onset of confusion or altered consciousness and occurs in a fluctuating manner. The cause of delirium as death approaches is often multifactorial. Common causes are medications, infections, organ failure, metabolic disturbances like hypercalcemia or hypoglycemia, pain, cytotoxic or radiotherapy treatments, withdrawal from alcohol, opiates, or benzodiazepines. Non-pharmacological management should always be part of the plan and may involve a peaceful or familiar environment, the presence of well-known people, avoidance of very dark or bright light, aids to minimize sensory deficits like having hearing aids in. Pharmacological treatment often starts with haloperidol. However, if not tolerated, risperidone, olanzapine, and quetiapine. Worsening delirium may be treated with a sedative. In respiratory distress with secretions, a client's inability to cough effectively or swallow in clear secretions from the oropharynx and trachea causes secretions to pool in the throat. This creates a rattly breathing sound which can be distressing for family to hear. Repositioning is advised as it may help shift pooled secretions. We don't recommend suction because it can stimulate a gag reflex and cause distress, as well as stimulating the oral mucosa to produce more saliva. Anticholinergics such as glycopyrronium and hyoscine butyl bromide may be required. With shortness of breath or dyspnea, changes in breathing pattern are a normal part of the dying process. However, if a patient appears to be distressed by difficulty in breathing, consider measures such as a fan to the face or good air circulation, and maybe a low-dose opioid or benzodiazepine. Oxygen should not be used routinely for respiratory symptoms in the last days of life, as these are usually related to metabolic changes rather than hypoxia. Oxygen can be burdensome for a patient. The tubing on the face can be disturbing, and flow into the nostrils can dry out the mucosa and cause irritation. In the last days of life, an agitated client can present as restless and unable to find a comfortable position in bed, trying to get out of bed, plucking at the sheets or the air, groaning and speaking without making sense. Much like delirium, there can be many causes, including physical, emotional, and spiritual distress, medication toxicity, and metabolic changes. Medication for agitation often involves identifying and addressing the potential underlying causes. If agitation persists, despite these measures, medications such as midazolam and clonazepam are commonly used to ease these symptoms. I'd like to read an excerpt on existential distress now. Another event at the Elsterhorst had a marked effect on me. The Germans dumped a young Soviet prisoner in my ward late one night. The ward was full, so I put him in my room as he was moribund and screaming, and I did not want to wake the ward. I examined him. He had obvious gross bilateral cavitation and a severe pleural rub. I thought the latter was the cause of the pain and the screaming. I had no morphia, just aspirin, which had no effect. I felt desperate. I knew very little Russian then, and there was nobody in the ward who did. I finally instinctively sat down on the bed and took him in my arms, and the screaming stopped almost at once. He died peacefully in my arms a few hours later. It was not the pleurisy that caused the screaming, but loneliness. It was a wonderful education about the care of the dying. I was ashamed by the misdiagnosis and kept the story a secret. I'm going to summarize the medications that we've been through with regards to the end of life. So, as discussed, the most common medications for pain are opioids. For dyspnea are opioids and benzodiazepines. For delirium are haloperidol. For nausea, metoclopramide, haloperidol, and ondansetron. For anxiety and agitation, benzodiazepines and antipsychotics. And for secretions, hyoscine butyl bromide and glycopyrrolate. Take-home messages from this presentation. Patients and families have expectations. And they deserve for those expectations to be met. The The story I read from One Mind's Medicine, an autobiography of Professor Archie Cochrane, demonstrates the importance of being present for those who are dying. It's important to prepare the family and patient for an impending death and the symptoms that they may experience. And it's important to assess and manage symptoms throughout the process to evaluate their effectiveness. Never underestimate a caring presence to both the resident and their family. Thank you for listening to this presentation.